Welcome to the Wellness Revolution podcast, the radio show all about wellness in your mind, body, spirit, personal growth, sex, and relationships. Stay tuned for weekly interviews featuring guests that have achieved physical, mental, and spiritual health in their lives. If you'd like to have access to our entire back catalog, visit drveronica.com for instant access. And here is your host, Dr. Veronica.
So welcome to another episode of Dr. Veronica's Wellness Revolution. Today, we're going to talk about something near and dear to all of us. We're going to talk about the heart. So heart disease and cancer kill more people every year than anything else. And cancer, it's preventable, in case you didn't know that, but we're not going to talk about cancer today. We're going to talk about heart disease. Heart disease is preventable. And people are saying, well, how do you prevent it? Because most people, they get sick from heart disease and they don't even know what's going on. So I always go to the horse's mouth and I get a heart guy to come talk to you. Now, you know, when you're a doctor, your heart guy is not your boyfriend, but your doctor, or a doctor who is a cardiac guy, a cardiac surgeon, a cardiologist, a cardiac transplant guy. Well, guess what? The doctor I have on today has been on heart transplant teams way back in the day when it wasn't even sexy, way back in the day. And he had a revelation that he was in the wrong field. So can you imagine you're a cardiologist, you're a heart surgeon, you're working with all those type of people, you're saving lives every day, yet you feel I'm being useless. We all have our revelation. One day I walked out of my office, said I'm never coming back to this because I felt useless because what I was doing for me to stay well, I wasn't giving to my clients. And so then I said, well, we got to change this. And this is what this doctor did. Dr. Doug Harrington. Now, I got to tell you, the man's a heart surgeon, but he's a stud too. Now, I hope he doesn't mind saying that. But he's got 6 kids, so I can't even figure out. Guys that I know that do anything in heart, they don't have the time to have all these kids. He's got 6 kids and a grandkid. Can you believe that? But Dr. Doug Harrington, like I told you, been on a heart transplant team and has actually founded a company and developed some innovative ways to figure out what's going on with people's hearts. You have to know about this. So I'm going to jump right in, introduce Dr. Doug Harrington. I'm going to let him give you some of the background of his story because it's quite interesting what made him have, I don't know what religion you are out there, but the come to Jesus moment where he said, this ain't it and I got to do something else. Dr. Doug Harrington, welcome.
Thank you, Dr. Veronica. It's great to be here again. I love talking to you. You've got so much energy.
You know, because this is fun because I get to talk to people like you. So, your story. Tell me about your story. Where you start a little bit back. What made you decide to go into the heart matters in the first place?
Well, you know, it was a very exciting time back 30 years ago when heart transplants were going on. And it was kind of like, if you could be a part of that, it was like, wow, this is so cool. And it's really interesting to sit there with a patient on the operating room table and the old heart comes out and it looks like a big bag of worms. And you have this empty chest there for a few minutes. And then you put this new heart in and it looks so tiny compared to the old heart. And you sew it in, and then you give it a gentle shock, and boom, it's beating again. It was a very amazing experience. But as you pointed out, after about 30 of these, I realized that the majority of them were preventable disease. And I looked at myself in the mirror one day and I said, you know what? It's really amazing that we can do all these things, but wouldn't it be more amazing if we never got to that point in the first place? Do you know what I mean? And so it just that was my epiphany of prevention is really the way to do these things. And so I left surgery and started studying things like cancer and heart disease and autoimmune diseases to see what was going on. And it was really a friend of mine who I was working on a breast cancer test to try and figure out what women shouldn't get chemo. And he's a very famous oncologist, and he was about 50. And he wanted to go scuba diving with his youngest son in Mexico. So he went to get a complete workup, got stress test, the whole kit and caboodle, was told he was healthy as a horse. He went out a week later, scuba diving with his youngest son, and he died in the water of a massive heart attack. And I just said, you know what? We're deceiving ourselves. There's more to this story than cholesterol. There's more to this story. We need to do a better job on this. So it started me looking at what was really going on there. And that's how I got involved in developing this blood test that we may talk about in a few minutes.
So you say there's more to the story than cholesterol, and I invariably have people coming to me, everybody's stressed about their cholesterol, it's too high. What do you mean there's more to the story? Because in conventional medicine, the holy grail is, what's that total cholesterol, what's that LDL?
You nailed it right there. And that's the biggest false sense of security that we perpetrate on people. So here's the deal. The American Heart Association did a study on people. Their first hospitalization for coronary artery disease, they looked at 137,000 hospitalizations. 83% of those people had normal LDL cholesterol. So you know right out of the hat that if all you're looking at is cholesterol, you're missing this boatload of people that are severely at risk, and they don't know it. And so that didn't seem right. So, you know, that was another story that basically said, we need to take another look at this. What's really going on here, you know? So
now we know cholesterol really indicates something else and is not the main marker for heart disease. What should people be thinking about now? I mean, everybody's fixated on the cholesterol still. Statins, I think, are the #1 prescribed drugs in people. What's the matter? What's the matter with those? Talk about that from the perspective of a heart doc.
Yeah, so things like cholesterol. Cholesterol is just one risk factor of many. Things like family history, if you're diabetic, you have high blood pressure, you don't eat right, you don't exercise, you know, you live in an environment that's very polluted. They all impact you. So if all you focus on is cholesterol, it's you know, a lot of things correlate with heart disease. A handshake correlates with heart disease, but that doesn't really tell you that you have any damage. So what is the real cause of atherosclerosis? Well, it's actually free radical damage to the lining of the arteries in the heart. And free radicals come from a lot of places. Cholesterol is just one of them. If you have excess sugar in your diet, it induces free radicals and other things in your body. Like vitamin C, if it's not recycled, can be a free radical. Glutathione, if it's not recycled, can be a free radical. Oxidized hemoglobin is a very common free radical found in your blood. And they're like, I tell people it's like a Velcro ball that you throw at the wall and it sticks because they have an electric charge. And what happens is when they try and peel off, they damage the lining of the artery. And at that point, your body says, hey, something's wrong here, come and fix it, so it activates your immune system. And that is the inciting event for atherosclerosis.
So if people cannot look at cholesterol at this point, how do you know if you're at risk for having a heart problem, a heart attack?
So I'm glad you asked, because I spent 15 years looking at that problem. So I do want to say that it's important to know what your cholesterol levels are, because the higher it is, the more it correlates with the development of disease, but it doesn't tell you have disease. So what we did is we started with mice, because the lesions that kill you are soft. They don't have calcium, and they're usually asymptomatic. And mice don't get hard plaque. They don't get the hard lesions that humans get when they've been around for a while. So we looked at them and we identified 250 proteins in mice that were either upregulated or downregulated when these lesions formed. And then what we did is during coronary artery bypass surgery, we biopsied human lesions and showed that most of those proteins were conserved. And then what we did is we said, well, we can't create a clinically useful test with 250 proteins. Let's narrow it down. So we narrowed it down. And then we did something that's way different than everybody else. We said the biggest killer of people is acute coronary syndrome. So we said, let's take all those biomarkers that we found, let's take all the global risk factors like age, sex, do you smoke, blah, 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 and all the biomarkers that were currently in clinical use like CRP and myeloperoxidase. And we're going to let software determine which of those permutations of those 60 or so items are best at predicting whether you're going to have an acute coronary syndrome. And we use 3 different software systems to test all of those, thinking that if 2 of them agreed, that was a good thing. It turns out that all 3 agreed. They picked the same 9 biomarkers and the same 4 clinical risk factors, which were age, sex, diabetic status, and family history. And we were able to, in a cohort of patients, and I'm using our study, the last study was done independently at the National Institute of Health. They took blood that was drawn 8 years before the patient's blood was given to us. It was stored at -80. And they measured it with our test system and said, can we predict who went on to have an acute coronary syndrome? And that blood test, it's a serum blood test, predicted 61% of the patients that actually went on to develop an acute coronary syndrome. Now, that's okay because we were testing the blood way after the fact, but that's called a retrospective prospective study. And what that means is, since we took blood at the beginning when there was no clinical evidence of disease, if we identified that they had a risk at that time, we could have intervened with lifestyle. And when you give data to people and they can understand it, they're more likely to pay attention to it. They're more likely to lose weight, eat better, exercise. And in some cases, they need drugs or interventions. And so we waited until we did that study, and then we published it, and we decided to get it into clinical use. And I'm skipping a whole bunch of other things here just to get to the main topic. So now what we have is we have a blood test, which it identifies that endothelial damage. Endothelium is the cells lining the arteries in your coronary arteries. When that gets damaged by a free radical, we can quantify that by measuring the body's immune response to it. So we're not testing cholesterol. We're testing something different that complements cholesterol. And it turns out that has given us a lot of power to identify people who are at risk of disease and don't know it. And we've seen a lot of successful interventions and lifestyle changes in people and blah, blah, blah.
So is this in people who have elevated cholesterol, or are these in people who do not have elevated cholesterol? Because there's that percent of people who don't have elevated cholesterol and still have cardiac events. So
right.
What are you looking for?
The majority of these people have normal cholesterol levels, and they can even be on some medication. And most of them are asymptomatic. And so the bottom line is, these are people, as you know, heart disease, half the people who have heart disease, their first presentation is they either die or they have a heart attack. They have no symptoms. And this year there was a paper that came out of Baylor on a cohort of patients called ERIC that showed that half of all heart attacks are silent. And that means is those people did not experience the usual symptoms that you get when you have a heart attack. They used MRIs and CT scanners to look at these people to determine they had scarring in their heart muscle that indicated a past event. And that's important because those silent heart attacks mean that those people were twice as likely to die in the next 12 months, and they didn't know it, you know? So.
What about this, I'm blanking on the name of it. I want to say cardiac calcium scanning or something like that. I hear all the radiology groups advertising on the radio, come up and have this scan done. What about that?
So calcium is actually a great measure of total plaque burden, and it correlates with long-term heart disease. But the lesions that kill people are not detected by calcium scores. They're soft lesions. They're called fatty or fibrofatty lesions. And the test I'm talking about is called the PULS cardiac test. It stands for Protein Unstable Lesion Signature. And it detects those fatty and fibrofatty lesions. So the test I'm talking about complements calcium lesions, a calcium score. The problem with the calcium score is it's not very good in women because women get soft plaque mostly.
Okay.
And it's not very good in men between 40 and 50. And And, but it is a valuable test if, for looking at plaque burden and that sort of thing. So we actually support the use of it, but we don't think that it should be the major determinant of your risk, So, and I have to be careful because I have a lot of friends that do calcium scores. So
I know my opinion is that we have to use all these pieces of information in concert. I think there's just so much focus on cholesterol, and we're saying, well, cholesterol is not what we need to be looking at exactly right now. So tell us again, you have the PULS cardiac test. PULS stands for?
Protein Unstable Lesion Signature. And it's a play on the word pulse, obviously. It's, boom, boom. Last time we talked, we were just this little tiny group of people here that were dedicated to preventing heart disease. We now have 2 national distributors in Canada and the United States. In Canada, the test can be obtained through Life Labs. They're the 4th largest laboratory in the world. And in the United States, Cleveland Heart Lab, which is a spin out of Cleveland Clinic, is our distributor for physicians' offices and naturopaths, and they go into integrated medicine and concierge medicine and stuff like that. But so we spent a lot of time doing the research, and the goal was to find a simple way to identify these people, get a clean bill of health, and go out and drop dead of a heart attack before that happens. And that's...
So who do you recommend get this type of test?
So it should be done on men and women aged 40 or older. And if it's normal, it has a 98% negative predictive value, which means you just have to maintain a healthy lifestyle and you'll be fine, However, if it is elevated, you have to take it serious. And it doesn't mean you need to have surgery or you're going to have a heart attack. It's more akin to your check engine light went on and you need to do a tune-up on that engine. And I can tell you that the majority of people that come in and I see, and we've done thousands of these now, they'll say something like, I eat right and I exercise. And you know what? A lot of times they're not telling the truth. And that's not a criticism of people. It's just you don't want to admit that you're eating those Cheetos at night, watching TV and not moving your rear end. You know what I mean?
Yeah.
So you can give them some information in the form of our test that basically says, well, you know what? This says you're not doing the right thing. You know what I mean? And we can even be more specific. We can say, you know what? I know that you think you're eating a good diet, but this particular component here tells me that you're eating too much sugar and refined carbs and probably deep fat fried foods or drinking too much, and it's damaging your arteries. So you need to back off on that. And we have great compliance once we give people that information,
So the PULS test is meant to be a screening test of sorts.
Well, it's both diagnostic and predictive, and it's a little different because, so for instance, if you take the Framingham risk score, which is supposed to be the gold standard for cardiac risk assessment, it doesn't actually tell you that you have disease. It just tells you that you have the risk of developing disease. The PULS cardiac test can be considered a risk score because it is predictive of a future event, but it's also diagnostic because it's quantifying the damage to your coronary arteries. So it's diagnosing subclinical disease. And I would prefer to call it preventive because we're catching people before they end up with an event. I have so many patients that we've caught just in time by doing this blood test, and oftentimes it's the only thing that was abnormal, and it precipitated a closer look at those patients, and they're doing very well, so yeah, that's, it complements everything that people are doing. It doesn't replace anything, and it doesn't replace coronary artery calcium because it's a different look at the patient,
So if someone does have a high score, does that simply say you're eating too many McDonald's French fries? I shouldn't say McDonald's French fries. French fries in general, too much fried food. Is that? Can you get more precise with giving the person recommendations? And once you give the recommendations, can this score be used to follow how they're doing clinically?
Absolutely. And I'm going to give you an example because this is more commonly what we see. One of my patients is a 52-year-old physician, and his lipids were normal. He was taking a statin once or twice a week, not in a high dose, just kind of a homeopathic dose. And he had been pre-diabetic for about 10 years, and he was changing his practice to a different type of practice. And we ran his lipids. His lipids looked pretty good with one exception. And we ran his pulse test. And for his age, his pulse test was 8.75%, which is almost 5 times expected for his age, because we know what you should be if everything's normal. And that really scared him. But the thing that caught his eye the most, because we also provide a heart age, is that he being 52, his heart age was greater than 80.
Wow.
And that heart age is what captures people's attention more than anything else we do. And so I said, well, you know what? Would you like me to actually put you on a real statin dose since you're already taking one? And he said, no. I said, Doug, I know what I'm doing wrong. Give me 4 months. So we said, okay. We came back 4 months later. We measured him. And he went from 8.75% down to 2.34%. And
Wow.
that he went from high risk to normal. And here's what he did. What I didn't tell you is that when I went into his office, he had a cake and candy and cookies, and he was indulging his sweet tooth because he thought his cholesterol was okay. You know what I mean?
Yeah,
And
just sugar will get you.
I swear the biggest problem in the American diet is sugar. And so what he did during that 4 months is he walked 30 minutes 3 times a week, and he didn't have time to go to a gym, and I don't really particularly care for that. So we just said, get some 5-pound dumbbells, and instead of sitting down watching TV 3 times a week, stand up for 20 or 30 minutes and go through range of motion exercises, because resistance training is actually more effective at stabilizing these unstable cardiac lesions. And he cut out the refined carbs and the sugar, and like I said, he walked. And during that 4 months, just doing that, he dropped 16 pounds. And more importantly, his heart age came down from greater than 80 to 53 or 55. I don't remember exactly what it was, but it was close to his age. But even more remarkably, for the first time in 10 years, he was no longer pre-diabetic. His hemoglobin A1C normalized. And he was so impressed. I mean, and this was just lifestyle modification. You know, this is not, you know, he was not taking a statin dose that was even homeopathic. It was like sprinkling, you know, powder into the wind or something. It wasn't really going to make an impact. So, and the message there is that this score is one of the few that actually goes up or down. So there are several potential outcomes. One is, with time, annually, if you do it every year, because age is one of the inputs, it will go up a little bit. So one of the good outcomes is if you stabilize it, it doesn't keep going up. A better outcome is if it goes down. What you don't want to see is that it goes up more dramatically. And
well, that person just went hog wild. That's what you know about them if it goes up.
Yeah, yeah. So like another patient that, as an example of how quickly these things can progress, is we had somebody that's 70-year-old who was part of one of our clinical trials. And a 78-year-old should be in what's called the borderline region under the American College of Cardiology guidelines. They have low, intermediate, and high risk. So they would be intermediate. That's normal for a 78-year-old. But at that time...
Of course. Yes, I do have a fax machine.
That's okay.
Yeah, what is that? I only have it so people can send me things like lab tests like that. You know, people who are old school. So yes, I'm sitting here by the fax machine. Okay, so he was 78.
He was 78, 3.6% a year earlier. And his daughter brought him back in a year later and said she didn't think he was right. I said, well, you know, I talked to him. I said, do you have any complaints? He said, no. She said, he just doesn't seem to have the energy that he did a few months ago. And you know, that's kind of what's considered an atypical syndrome. So we reran, he went to his HMO, and they did the cholesterol, and everything was normal. and they did a carotid intimal medial thickness ultrasound. It was normal. His blood pressure was normal. And because of all of that, they discharged him, but his daughter was just not happy with that, so she took him to an out-of-network cardiologist. He ran the pulse test. He repeated the pulse test. The pulse test in that 12 months had gone from 3.6% to almost 46%.
Wow.
Yeah. And the only difference during that period of time was his wife had almost died 2 or 3 times, and he was the primary caregiver. So he was very stressed.
Correct.
And the reason I bring this up is because everybody forgets about stress. And you'll see actually in some of the associations like the American Heart Association, there are people who have actually said stress doesn't cause heart disease. That is not true. Stress is it's implicated in cancer and heart disease and autoimmune diseases. And so what happened was the out-of-network cardiologist sent him back to his HMO, and when they saw the results, they took it very seriously. They went in and they did an angio on him because he had what he was saying was his daughter was saying he didn't have the energy. He was ascribing to just being old, getting older. And she said, no, he's not like that. That's not right. So they took it serious. It's an atypical symptom. And when they did the angio on him, he had almost 100% occlusion of his LAD. There was blood flowing through it, and it was imminently going to rupture and probably would have killed him because it's the artery of sudden death. They stented him and put him on medications. You know, this is a little further along than lifestyle modification would allow. And today he's doing very well. He looks like a much younger man. And I use that just to illustrate 2 points. It will go down and it will go up. And if you're stressed, it'll go up. Mine went up when I was getting an IRS audit, and it went up.
Oh, God. Everybody's would go up with an IRS audit. Yeah. So the pulse test sounds so wonderful, and people are asking right about now, where do I go get one? Where do I go get one? How do we go about getting a pulse test if that's what we're interested in?
Yeah, so since the rollout is just starting nationally, the first thing I'd recommend is they go to pulsetest.com to learn more about it. It's PULSTEST.com. And then they can contact Cleveland Heart Lab. They can look it up online. Contact Cleveland Heart Lab and tell them that you're interested in the PULS, PULS cardiac test, and they will contact you. Alternatively, you can send an email to the pulsetest.com website, and one of our client services people will contact them and help them find out where they can get it done. Okay?
That's so funny. I was gonna open an account with Cleveland Heart Lab, and the guy came and visited me, and I just never got around to it. So now I got to get my Cleveland Heart Lab account so I can offer it to my clients. So that put a kick in my butt right there.
Okay, well, good. That's what we wanted to do. No, they're a very good partner, and they're very ethical, and we're always available to consult on results. We deal with people all over the world now, so it's very gratifying. So.
Okay, so one last question. People always want to know this, and let me just say, I don't think this should make or break whether you save your life, but is it covered by insurance at this point?
It is. It's reimbursed by Medicare and most PPO. We haven't had time to go to all the HMOs, but if a doctor from the HMO orders it, a lot of times it will get covered. And so the answer is yes. And then the cash price is actually not super high. So there's a cash price.
Range of cash price? I know this is not your forte, but the range of the cash price?
Well, it's around $150. It's about the same as an expanded lipid profile.
Okay.
That's Medicare. We don't usually go below Medicare pricing for obvious reasons, because that becomes your new price, you know.
Yes.
And then now we do have a not-for-profit foundation that if people do not have insurance or they have a ridiculously high deductible, that they can fill out a financial assistance form and get sometimes a lot of it covered. So we don't want to deny it to you just because of money. Okay.
Wonderful to know that. Great that you did that. Well, Dr. Doug Harrington, who has a new life purpose in helping save people's lives who we wouldn't know were even at risk for having a problem. It sounds like this test should be something that becomes a normal part of the screening for everybody versus the cholesterol. I got to say that.
Yeah. Well, again, I think we would like, that's our goal, but we don't want to, remember, cholesterol is still important just to determine your risk of developing disease. And it is something that is modifiable, and this doesn't replace anything, but this is a hole in what we're looking at on the patient that we can't see right now. And this pulse test lets us see that part of the patient and get a better idea of their true cardiac health.
Yeah, it would be great to be able to see the problem when you can really do something on the lifestyle front that's going to make a very big impact versus when you're seeing them and the gentleman was saved, he got the stent and everything, but we would like to get people so that they're way before that. So that's why I'm like, this sounds great.
And look at the gentleman that was 52. He didn't have any surgery or anything. He just did lifestyle, and he took his risk from high to normal. And in only 4 months. So that should give people hope that you do have control over your bodies. You have to make those decisions. You have to get off the couch and exercise. You have to eat the right foods, stay away from processed foods and all that sugar. And you do well, eat whole foods. That's it.
Yeah. So I don't even think cholesterol is scary to people anymore at this point. So, this right here, we know how predictive it is. So Dr. Doug Harrington, thank you. PulseTest.com, PULSTEST.com, if you want to find out where to get one. And
Dr. Veronica, thank you so much. It's always a pleasure to talk to you.
Thank you so much.
Okay, bye-bye.
Thank you for listening to the Wellness Revolution podcast. If you want to hear more on how to bring wellness into your life, visit drveronica.com. See you all next week. Take care.